I'm going to talk about fluid volume overload, also called fluid volume excess, also called overhydration. So it happens due to there's too much fluid in the body. This could either be due to inadequate removal by the body, like there's too much fluid in there and the body can't get rid of it, probably because of kidney problems, or too much intake, okay? So your risk factors, older adults are going to be at high risk for fluid overload. You have to watch them very carefully anytime you're giving them IV fluids, anytime you're administering blood, because they can go into pulmonary edema. So you need to really watch them. Older adults have a reduced kidney function. So that means they're not always able to put out the fluids that are going in quick enough, okay? Um, and it's also people that are getting excessive fluids like oral fluids, IV or enteral. People with syndrome of inappropriate antidiuretic syndrome, we talked about that in the cancer lecture because that's one of the oncological emergencies. There's other conditions that can cause syndrome of inappropriate antidiuretic syndrome as well. Let's talk about the labs. So in the labs, what you're going to see in somebody that is overhydrated is a low H&H. They are going to have a decreased BUN and a decreased specific gravity, okay, except for SIADH. Most people that with fluid volume excess are going to have a decreased specific gravity. They'll have low sodium. And the reason that the labs get low is because of hemodilution. In other words, the fluid in the vein is diluting the labs, okay? The expected findings, your patient may have edema, and I'm going to show you something about pitting edema because you're going to need to know how to document that. Or they could, get generalized edema all over the body, and that's called anosarca, okay? They're going to gain weight. Weight gain, when we're worried about people having too much fluid, we always put them on daily weights. And if they're getting boluses, they may even have their weight taken more frequently. Now, somebody with fluid volume overload is going to have tachycardia with a bounding pulse. Now, people that are dehydrated, which is almost the opposite, right? A fluid volume overload, they're going to have tachycardia as well, except they're going to have a weak, thready pulse. So think about it for a minute. If you have too much fluid in your body's going to start increasing the heart rate, but your pulse is going to be bounding. That makes sense to me because there's more fluid in your veins, in your bloodstream, I should say, in your arteries. But if I'm dehydrated, my pulse is going to be weak, right? They'll have tachypnea, meaning their respiratory rate is going to go up. Hypertension. They could have an altered mental status, and because of the low sodium, they could develop seizures. They could develop a new cough, especially at night. So if somebody has a new cough at night, I would definitely think about pulmonary edema, like their heart is not pumping this fluid effectively, and now it's ending up in the lungs. They'll have could have crackles and dyspnea. Pink frothy sputum, that occurs due to pulmonary edema. So anytime you hear the pink frothy sputum, think pulmonary edema. So again, let's analyze these cues. We are most worried about pulmonary edema and the pulmonary edema that could also occur with CHF. So our patients, I talked about a new cough, crackles, and dyspnea, pink frothy sputum. The chest x-ray is going to show pulmonary congestion. They will also be short of breath and have orthopnea. Orthopnea means they can't lie flat. So I don't know if you've seen anybody short of breath, but they sit up and almost tripod themselves. So you might have to put them in high fowlers, right? You would do that before you even put oxygen on somebody because that's going to help them tremendously if you lift that head of the bed. In a low O2 sat. So the thing we're worried about the most if we analyze this situation is potential for pulmonary edema, okay, which is going to impair their gas exchange. So they could end up with hypoxemia. So we worry about that. Now the solutions, let's talk about planning and the interventions we're going to do. So the mnemonic drain can help you. They're going to be given diuretics, and if their kidneys aren't functioning properly, they'll have dialysis. We're going to restrict sodium in fluids. We're going to assess daily weights. And you know the drill, right? The same clothes, the same time, void before, all that, okay? They're going to be on eyes and nose, and we want to check the sodium level. If we discover that our patient is in pulmonary edema, the first thing you're going to do is raise the head of the bed, stay with your patient. Always stay with your patient if they are in distress. Okay? Put the oxygen on them, keep them on bed rest. So if people have a lot of edema, bed rest helps mobilize the fluid in the body because the kidneys perfuse better. So we put them on bed rest. All right, you're going to turn them every 2 hours. They're going to be at risk for sacral edema. I don't know if you've ever seen sacral edema on somebody, but the sacrum is the dependent part of your body. So when somebody's on bed rest, the fluid tends to you know gather there. I don't know how to, so they'll get sacral edema. You want to turn Q 2 hours because they're going to be at risk for pressure injuries. You want to report and teach them to weigh themselves daily. A weight gain of 2 pounds a day or 3 pounds in 1 week. Okay, that is a constant intervention you're going to hear over and over again throughout nursing school. Now, to evaluate the outcomes, like, did we take care of this patient? Did they, is their fluid overload better? We want euvolemia. That's one of our goals. And euvolemia means simply the I's and O's are equal. In other words, there's not a fluid volume excess in the body. Lung sounds are clear. O2 sat is great. No more crackles in the lungs. Pink frothy sputum is gone. No longer coughing, right? Can lay flat comfortably. Does not need oxygen anymore. Can ambulate. All those things, right, tell us that our patient is getting better. Now, I need to teach you how to document pitting edema. Now, pitting edema, you evaluate it by compressing the skin. So you're going to press on the skin over a bony prominence, and you're going to hold it there for 5 seconds. Then you're going to let it go, okay? So you document it by measuring the depth of the indentation that your finger left, but also how long it takes for that indentation to kind of bounce back, okay? So in stage 1, I'm going to tell you an easy way to remember the different stages. Multiply the stage by 2, okay? So stage 1, 1 times 2 equals 2 millimeters. Stage 2, 2 times 2 equals 4 millimeters. Stage 3, so times that by 2, the indentation is going to be 6 milliliters. Stage 4, times that by 2 is going to be 8 millimeters, okay? Now, 0 means there's no edema. 1 is slight pitting edema, right? So that's 2, and it rebounds very quickly. The next one is grade 2, and 2 times 2 is 4. So the pit is a little bit deeper, and it rebounds in 15 seconds. Grade 3, 3 times 2 is 6. So the indentation is going to be 6 millimeters, and it takes 30 seconds. And 4 times 2 is 8, so the indentation is going to be 8 millimeters, and that takes about 30 seconds to rebound, okay? So it's really important that you know how to document pitting edema. All right, that's it for fluid volume overload.